Surgery. So my first talk is by Dr. Leila Mohan. Madam is the head of Academy Comtrist Eye Hospital, head pediatric ophthalmology and strabismus, and the chief operating anterior segment surgeon at Comtrist Eye Hospital. She will be giving us a talk on strategies for phacoemulsification in vitrectomized eyes.
Thank you, KSOS and Dr. Divya, for giving me this wonderful opportunity about cataract and vitrectomized eyes. Nowadays, we all know that combined surgery has taken over many of the issues in where there is retina posterior segment problem with cataract. So cataract formation or progression after 20 gauge pars plana vitrectomy can go up to 80% in 24 months, and use of small gauge vitrector leads to lower cataract formation, whether due to lower amount of BSS use, lower fluid flow, or shorter surgical time, we don't know yet. Early cases present with PSCC in younger patients, and later nuclear sclerosis, either onset or progression in older patients. And if it rapidly progresses, cataract within 4 months formation is there, we have to, even after Avastin injection, we have to suspect trauma to posterior capsule. So what is so challenging about surgery in vitrectomized eyes? There is a high rate of intra and postoperative complications due to lack of posterior vitreous support, which makes rhexis difficult. Poor pupillary dilatation and posterior synechia may be there. Occult zonular instability, which you may not recognize during clinical examination, or PCR may have been there. Fluctuations of AC common, which is common due to a collapsible globe with no vitreous support. And all these make all steps of echo difficult, and perioperative problems of iris damage, choroidal hemorrhage, all have been reported in about 13%. And therefore, planning of surgery from counseling, biometry, incision configuration, IOL design, and type of anesthesia is important. And counseling before surgery is very important to discuss with the patient the expectations of visual outcome. Better to decide surgery early for posterior pole visualization later, and also to avoid difficulties in advanced cataract. Visual prognosis should be assessed and discussed with the patient, whether it was due to a surgery was for an RD with macular involvement, PDR with macular edema, history of ocular trauma or high myopia. All of them can compromise vision due to macular problem. And whether defective vision is due to retinal pathology or cataract formation, also we cannot distinguish between the two. Metamorphopsia or central scotoma, which the patient has before surgery due to macular disease, can persist for after cataract surgery. All these have to be discussed with the patient. And use of dispersive viscoelastic, CTR, whenever necessary, and type of IOL should be discussed with the patient, and standby IOL should be there. Preoperative assessment is important. Pupillary dilatation may be poor in uveitic and diabetic cases, and phacodonosis, posterior capsular irregularities and outpouching. Sometimes you may see a track. Emulsified silicone oil or even large bubbles. Large bubbles may point to a integrity of zonules may not be there. It may be affected, and fundus OCT can be done if it is visible, if the media is okay. And in macular edema, sometimes intravitreal injection before surgery or during surgery may be needed. And B-scan if there is no view to rule out vitreous hemorrhage or retinal detachment, where combined surgery may be better. Plan for topical or subtenon anesthesia, especially when there is myopia. Better not to use retrobal bar, peribulbar. So IOL power calculation is also critical in these cases. Optical biometry gives more accurate measurements, and advantage of IOL Master 700 in fixation, especially in high myopes with staphyloma, because the OCT imaging is there. And Barrett's Universal 2 or Haigis gives consistent results. The effective lens position may be deeper than usual in vitrectomized eye, so we may have to add a 0.5 diopter. In silicone-filled eye, following retinal detachment, an anterior shift of the lens may underestimate the axial length and give a myopic shift also. This IOL power calculation by optical biometry can be directly read in a silicone oil chamber, and so it makes easier calculation. But when there is a dense cataract, immersion ultrasound is preferred. If silicone oil is used, a correction factor of dampening for dampening the sound waves from 980 to the speed reduces to 980 from 1532, and the erroneously long axial length may be obtained. So a correcting factor of 0.64 when we use 1000 centistrokes of silicone oil should be there. So incision of the is directed towards the center of the anterior chamber, which makes maneuverability easier, and scleral rigidity is low, so a small side port avoiding leakage, especially when there's an intumescent cataract with dispersive viscoelastic, is useful, which keeps the chamber well formed, and don't deepen the chamber too much because the rexus can go large. And use a microrexus forceps, which makes the procedures easier. So, nuclear sclerosis is the most commonly presenting cataract. When pushing trypan blue, see that too much blue doesn't jeopardize the red glow. There may be posterior synechiae which may have to be separated with a spatula, and there is upthrust due to silicone oil. So, do not overfill. Hydrodissection should be very gentle. Sorry. If you are not gentle enough, you may the rexus may give way, as you see in this picture. There is a, it's not very aggressive, but then if it is more, the rexus gives way. So to prevent this, it is better to dip the posterior lip of the incision so that some amount of viscoelastics is let out. And this is a very common issue, lens iris diaphragm retropulsion syndrome. There is sudden ingress of fluid which deepens the anterior chamber and pushes the iris back against the lens, and there is a reverse pupillary block, and sudden deepening produces pain, which is common in myopic eyes also, even without vitrectomy, because of the collapsibility of the globe, lower scleral rigidity. So lower the pressure or bottle height before entry of the phaco tip, and slow increase in pressure and lifting up of the iris as suggested by Sioni can be prophylactic and therapeutic. You can see there is an iris diaphragm retropulsion. As soon as you enter and the fluid is there, the iris pupil dilates so much so that you cannot even see the iris, and there is sudden pain also. So it can be prevented by setting a low ramp of IOP in active fluidics as in Centurion. It slows the buildup of pressure in the anterior chamber from 20 to 40 millimeters in a collapsible eye. So after entering, you can see after lifting up the iris with a spatula, then only enter with, and then fluid infusion is started only after lifting up the iris, which equalizes pressure in anterior chamber and posterior chamber. And if lens iris diaphragm retropulsion occurs, pupil becomes smaller later and the procedures can be difficult. So in nuclear disassembly, you also, when you start, use low parameters, low pressures to 30 millimeters or less, and vertical chopping is better. Use visco before phaco tip is out. You can see after the last piece of nucleus is out, keep the infusion going and push some viscoelastic so that the PC doesn't come up due to surge. And then careful cortical wash and polishing, and whenever necessary, if you are if you feel the chamber is not forming well in a collapsible globe, put a suture also. So this case, you can see if there is lot of phacodonosis when you do rexus, you can see the whole lens is moving. Use a CTR for zonular stability to prevent IOL dislocation with the bag in future. It is reported in about 19% of cases when you don't use a CTR. And capsular hooks also helps in doing nuclear disassembly, and which helps prevention of stress on the zonules. So in a soft white cataract, AC may be due to myopia and vitrectomy, and often posterior synechiae is there, and use of viscoelastics, and never try to implant on fluid as we sometimes do after doing this nucleus delivery. I don't know whether we can take time. I will. Sometimes posterior plaques are not uncommon. We can try removal of the plaques on the table, or sometimes you can leave it alone for doing a YACAP later. And when there is an extension of PC rent, you can, and the rectus anterior capsular rectus is intact, you can do a posterior optic capture with a 3-piece lens, which should be there in every case. It can be expected, and push the optic behind the PC opening so that the IOL is stable in the anterior chamber. Okay. When you may have to use pupil expanding devices when pupil is small, and look for IOP. Post-op follow-up is important. You may need to follow them up more often than in a routine case, and often patients feel it's all done, and counseling is very important, that they should have follow-up with the retina surgeon. And these are some of the points to be remembered. With some planning, it can be a safe procedure, and a good outcome is possible. Thank you.
Thank you, madam, for that wonderful talk and amazing video.